infections in liver transplant and before I start, the outline of my presentation will be like understanding what's the difference in liver transplantation with chronic liver disease who come from liver transplant, how are they different from the rest of the sector of the population, and why are they considered to be immunosuppressed. The next is what kind of infections, what do they affect during the course of transplant and in the post-op. So, advanced liver disease patients are different. We'll see how is it. And do they need higher antibiotics even for prophylaxis? Why should I use? So, it's like this. A patient who comes with a kind of a tachycardia, hypotension, and kind of a respiratory distress, would I dare to start him on a basic antibiotic? The history is like this. The patient has been through multiple admissions in ICU and has gone a very big infectious history, a lot of cultures positive. Probably no physician would dare to start him on a basic antibiotic. So, should I choose a broad spectrum or a carbapenem for every patient? That wouldn't be right. Probably I'll be able to save one patient, but I would be losing on my antibiotic and I'll be doing more harm than good if I treat a patient who has no clinical infectious history in the past. So how do I choose? Let's see. So here I would like to show you a journal from a clinical transplant. We could focus on American Society of Transplantation. So this says carbapenems are the agents of choice for treatment of extended spectrum beta-lactamase infection, particularly Enterobacteriaceae family. And this also states the beta-lactam inhibitors like ampicillin sulbactam or piperacillin tazobactam, they should not be used as first-line therapy for severe ESB. At this point, I would like to quote the Merino trial, which tried to compare the piperacillin tazobactam and meropenem for patients who are having ceftriaxone-resistant E. coli. This trial was abandoned in the middle because it couldn't achieve a non-inferiority with respect to meropenem, and the result of the trial was it was associated with a high mortality at 30 days. So what should we do? Second generation beta-lactamase inhibitors like ceftazidime avibactam and ceftazidime tazobactam to be used for these kind of infections. I am presenting a few of my culture reports of my patients, and we do see these type of regular. Here, this is an infection of urine, which is significant, Klebsiella pneumonia, a kind of a PDA. And here there is another infection with drain fluid, Enterococcus gallinaris, which is also a kind of a multi-drug resistant, only sensitive to PDC. And here I also have a culture report which shows Enterococcus faecium, which is a PDA. And to say, this is an article which shows this E. faecium carries almost 69% mortality in immunocompromised India. So where does this take and how serious should I be with respect to treating it? As we know, liver transplantation is for individuals who have acute or chronic end-stage liver. But in this pattern, a lot of people might end up repeatedly in ICUs with different infections, and a few might come directly to the transplant without facing any kind of ICU. In my experience, we have seen both kind of treating one patient in the wrong way end up in bad. So let's see how these patients are different. Liver transplant, people who come from liver transplant, they have a kind of immunocompromise, that is due to increased gastrointestinal permeability because of ineffective tight tension, or it can also be due to a deficiency of IgA, or it can be due to increased translocation, either it can be due to bowel distension or whatever reason, prolonged hospitalization, and the use of invasive devices or the chemo. All these lead to a kind of nosocomial. Usually, patients who present with cirrhosis, they have 30% community acquired, but rest of the 70% are hospital acquired. And out of these, 30 to 40% of healthcare infections occur usually greater than 48 hours of stay in the hospital. So obviously these patients will be having multi-drug resistant infections, and these infections usually are not clear, they are colonized. What I mean to say is, in the repeated history of the person, the patient tends to get infected by the same bug often. So if the patient gets next time to the hospital with a bad condition, probably he is being affected by the same bug which has infected him, and every infection carries a 15% risk of mortality in the hospital. So in sense, I would say that patients with advanced liver disease have structural abnormalities, and they have reduced production of critical immunoprotective proteins and reduced immune cells or infant. Hence, we can consider them a kind of immunocompromised individual. Now, let us see what kind of infections turn up in liver transplant. Usually, a patient having any issues of after liver transplant has these kind of problems. TII. The first one is technical, second is infectious, and the third is immunological. All the three are correlated. You have technical issues, you can have infectious issues. If you have infectious issues, you can have technical. But majority of the things, if you have a good team, a good surgeon, probably the technical issues will be minimal. So out of all the infections, bacterial infections carry 70%, followed by fungal and viral. The virulence of the pathogen, intensity, time of exposure, and the presentation to the hospital determines the outcome of the factors like MELD score, which is more than 30, re-surgery, that is the re-exploration, renal replacement therapy, prolonged use ICU admission, and use of steroids. These kind of things can actually worsen the outcome of the. Here I have a good diagram which classifies the infections into three kinds. The first one is less than 1 month from liver transplant. The second one 1 to 6 months, and the third one greater than. The logic is simple. In the first month, the patient is usually hospitalized, and there we have a lot of insertion of the catheters, indwelling catheters, and we are high on immunosuppression. That is where the liver tries to set in, and the patient is also exposed to the hospital-acquired infections by the hospital staff, and he can catch infections from the ICU hospital. So here the infections are majority are hospital-acquired, and the site of infections could be bloodstream, pneumonia, skin and soft tissues, intra-abdominal, and clostridium difficile, viral infection, HSV, and viral. From 1 to 6 months, the patient usually stays at home, so he is more exposed to community-acquired infections. Community-acquired infections are not so virulent, slightly easier to treat, but as I told you earlier, previous colonized infections can take a repetition. So if the patient comes with a virulent and a bad organism, probably it is one of the previous colonized organisms, and probably I will try to treat with the same antibiotic which was sensitive previous. And the last group is greater than 6 months. Here the patient is usually set right or goes into the wrong state. Here the patient usually has a problem with rejection or some technical issue. So these patients present with most with community or hospital-acquired. And here, like bacterial colonization during the perioperative period results in the same pathogen as I told you earlier, and there are some other factors which determine what kind of infections or who are considered as high risk. For example, a patient who has a repeat surgery or who has going for a retransplantation or re-exploration, they are considered to be a higher risk. And the patient who has undergone massive transplant, they are considered to be good choices for higher escalation of antifungal. So based on all this, the patient's progress is decided. And there are also certain post-surgical complications like hepatic artery thrombosis, biliary strictures, which can increase the risk of cholangitis. Mortality has been reported as high as 86% with MRSA bacteria and MRSA in abdomen. And when we see the ESBL producing organisms, they also have high prevalence and they have higher mortality. Usually the kind of infections which we encounter, ESBLs are from E. coli and the colonizations with Epsilon producing bacteria has been reportedly increased. Carbapenemesis of KPC kind, it is more in the West. But in India, we do face Oxa 48 and NDM variety and also some other varieties, depends on the institute. And as we see, due to this repeated infection or whatever, we are facing a kind of increased incidence of PDS. And these are usually from the carbapenemase producing enterobacteriaceae like Pseudomonas, Klebsiella, E. coli, and Enterobacter. And this is posing a serious issue, and probably we'll have to save our patients and antibiotics. So, dealing with PDS is a huge topic, but just I'll let you touch here. Using carba, we would like to know what kind of a carbapenemase is being produced, like Oxa 48 or NDM or if it is VIN. Knowing the carbapenemase, we can choose our antibiotics wisely so that we don't overtreat the patient or under. Here I have a test report with VIN and NDM, and here and another category. So how do I do? These days for band-drug resistant infections, we are having synergistic combinations. One such example is ceftazidime avibactam with aspirin. Several synergistic combinations have been effective in treating PDR GMV organisms. Like ceftazidime avibactam, meropenem, polymyxin, and sulbactam for Azithromycin and some other. Here I have a big list of. So a double carbapenem nor a ceftazidime avibactam is functional in case of MBBS, that is metallo-beta-lactam. So what do we do? This is a serious issue which we have to do. In such cases, the grace is aspirin is not hydrolyzed by MBL, and avibactam effectively inhibits other beta-lactamases like ESBL, KPC, and octapod, restoring the activity of aspirin. But unfortunately, in today's market, we don't have aspirin and avibactam combination. One of the pharma companies currently is producing avibactam, but in future, aspirin and avibactam might be available by 2020. So now let's see into Clostridium difficile. These range from 3 to 19% in OLT resistance, usually higher in the first 3 months because of higher antimicrobial exposure or intense immunosuppression and a frequent immunosuppression hospital. In mild to moderate infections, usually IV metronidazole or oral metronidazole can be, and in severe CDIs, usually oral vancomycin 125 milligrams every 6 hours. And if it is severe CDI associated with reduced gastroenteritis motility, we use a combination of vancomycin and intravenous intervention. Fungal infection. All of the chronic liver disease patients are thoroughly trained for fungal infection. For instance, patients are screened for this paranasal sinus infections because often we might see fungal balls growing. Such patients deteriorate rapidly after the surgery. So if you have such kind of patients, it's better to treat them and then only take them first. Candidiasis and aspergillosis is the most commonly encountered infections in case of liver transplant. Candidiasis is usually seen in patients who are on previous history of steroid, renal replacement therapy, and prolonged surgery or massive transfusion. Massive transfusion, we label it like more than 10 packs further. And aspergillosis can also occur in case of ICUs which are near to building activity and all because force can contaminate. So in such kind, we need to identify individuals with higher risk for fungal infection and try to go for a higher fungal like echinocandins or liposomal amphotericin for a period of 7 to 14. So the usual choices are fluconazole and echinocandins which are used for targeted prophylaxis, and high risk patients we do give for 7 to 14 days after liver transplant. Viral infection. CMV is the most common viral infection that comes after liver transplant. It is usually present in the first 3 months. That is the reason we give prophylaxis for the first 3 months. After 3 months, usually the immunosuppression is tapered, so the chance of CMV slightly less. And whatever viral agents, antiviral agents we usually give for CMV also help in HSP and varicella. So the routine preferred things are Valgan cyclovir and IV can cyclovir. These are used for prophylaxis. Thank you.
Thank you, Dr. Meher, for a very good presentation. But one thing I would like to add here is that Astronome avibactam combination, as you said, it is not available here.
Yes, sir, not available.
For those bugs which are having, I would say, XDRO, extended drug resistant organisms, which are sensitive to only 2 classes of antibiotics. In that, we have used in our hospital a combination of meropenem and astronome, or sometimes a combination of meropenem and colistin because of the bacterial action, the resistance mechanism it has through the bacterial cell wall. And the first slide which you have presented saying that if you come across a patient with a ESBL, so instead of going with BL-BLI combinations, the beta-lactam or beta-lactamase inhibitor combination, can go directly with the carbapenem. I think this will not hold true for all the ESBL producers.
Exactly.
Only those ESBLs with the AMC producer, where you have to use carbapenem. So that technique we need to have in the microbiology department where we can at least find that it is a ESBL with the AMC producer. So for that reason, we have to keep a close eye on those patients and still start with the BL-BLI combination 25.